So is it over to me now?
Yes.
Hi, everybody. I'm Claire Heffernan. I'm the director of LIDC, and I want to thank both the speakers and you for joining us today. Now, we entitled our seminar Sliding Backwards, SDGs in the Time of COVID. And I think when we think about COVID and the SDGs, it's probably safe to assume that most of us will be thinking it's going to have a very deleterious impact on our ability to meet some, if not all the goals. And our speakers are going to really drill down into some of these issues today across a range of sort of goals and geographies. But there was another reason that we entitled this seminar Sliding Backwards. And I think because there's much wider sort of political, economic, and social issues that are coming into play now. And among the global development community, we're starting to hear these murmurs of a new order post-COVID. And I think it's very easy to look back almost with nostalgia at the time period that produced the SDGs. And like all global agreements, they reflected the political will of the time. And today, in the midst of this pandemic, I think it's safe to say that global political will is in very short supply. And the way that we've dealt with COVID-19 can only be described as a very fractured nationalism. So it's clear on a wider political level that the pandemic and SDGs are very antithetical. And I think this really calls into question, post-COVID, can these big global agreements survive? And I hope we can kind of touch on this across the discussions today. So I'm very excited to introduce our first speaker is Dr. Jasmine Guddian. And Jasmine is a senior lecturer in development studies at the Department of Geography, Environment and Development at Birkbeck. And she's the principal investigator on an ESRC GCRF network grant, Equalities in Public-Private Partnership. And her research interests include gendered political economy of health in Latin America and issues around health and migration. And her talk today is going to touch on the gendered structure of healthcare systems in Peru and the implications of COVID. And she's going to also talk to us about Peru's progress towards meeting the SDGs. So welcome, Jasmine. Thank you so much for joining us.
Thank you very much. I'll just share my screen. Yes. Okay, so yes, thank you. As Claire said, I'm going to talk about gender health and COVID in Peru today. And this is, well, I was in the middle of a project with a couple of colleagues in Peru, Camila Gianelli and Lucy Guñez, and also my colleague here in the UK, Maria Jose Romero, who's also works at Eurodad. And obviously we've had to unfortunately abandon our project, but we've started trying to kind of think about some other things. So some of the details that I'm going to present do come from work that we've done together and various things that they've sent to me. So yeah, so some people may already be familiar with the case of Peru, but Peru has been one of the hardest hit countries in Latin America, and currently it's the 12th, the 12th highest hit country in the world. Yesterday's figures were, as you can see, over 99,000 cases and nearly 3,000 deaths. And last week there was concern that hospitals in Peru were at in Lima, were at maximum capacity with 80% of intensive care beds taken up. The majority of hospitalization and deaths occurred in the public sector, as I'm going to outline in a minute. Peru's got a mixed health system with public and private sectors. But the majority of hospitalizations have occurred in the public sector, and this of course reflects the fact that the majority of population are in the public sector, but also the type of care that isn't available in the private sector. That actually public sector hospitals are better equipped for things like ICUs. And the gender differences are very clear. Again, these follow kind of wider patterns where the majority of cases are male, so just over 60% are male and 40% are female. And again, the majority of deaths are among men, 72%, while only 28% of the deaths have been women. And again, this is slowly kind of making its way into the international news, but there's been a lot of concern about what's going on in the Amazon region and in Peru. That's around the city of Iquitos, where there's very significant lack of medical supplies and medical resources. And although there's been talk of building a new hospital in the next couple of weeks, you know, it may be kind of too little too late. So as I said already, Peru has a mixed health system. The majority of the population are registered with the public sector, but even within the public sector, there's different modes of provision. So the predominant one is the Ministry of Health, called MINSA, where 60% of the population are in that. 30% of the population are covered by social health insurance. So this is where you would pay for health coverage through your salary, but that's a public scheme. And the rest of the population are covered by particular social insurance schemes provided by the armed forces, the police, and also the private sector, so more of kind of high income groups. And low-income groups are covered by the Ministry of Health, but there's a specific program called the Seguro Integral de Salud, the SIS, which was introduced in 2002 and was a kind of flagship program all about promoting universal health coverage. So again, quite key, a kind of key strategy in working towards the SDGs. And although there are restrictions on eligibility for the SIS prior to COVID, migrants and refugees were not eligible. Recently, I think last month this started, the scheme has been extended to migrants and refugees, so they can now get some kind of healthcare provision under COVID. But in the kind of normal state of affairs, actually SIS only covers a kind of prioritized set of conditions, so kind of limited health conditions are covered by it. So there's a kind of basic health package, but currently that does include treatment for COVID and burial expenses. But as I'll go on to talk about, one of the big questions, one of the big challenges is around quality of care, rather than what's kind of theoretically included in these packages of treatment. And yeah, again, like many other health systems, both in Latin America and beyond, the Peruvian health system is quite gendered in terms of its sort of hierarchical organization and the where within the system men and women are located. So women, because they are in lower paid, low status forms of work, they're more likely to be in the SIS, whereas men who are more likely to be in formal jobs where they earn regular salaries are more likely to be in Salud. And so again, some people may be familiar with the kind of recent history of Peru, that in the last few decades they've emerged from very kind of brutal civil war that was very much organized along kind of racialized lines. And this, again, the kind of gendered and racialized historical legacy of civil conflict in Peru is very evident in the health system. And what I mean by that is that access to and experience of healthcare is very much shaped by social identity, so particularly around gender, race, class, age and locality. And again, as we see in the case of Iquitos, indigenous communities are very excluded from the health system in normal times, so let alone in the case of COVID, they've been extremely overlooked. And again, despite a lot of kind of investment and progress in the health system in the past couple of decades, there's still a big problem around the lack of culturally appropriate health services, and this has continued to kind of exclude indigenous communities. And again, there's some interesting work that's been done by a Peruvian anthropologist who looks at the way in which even within indigenous communities, women are particularly likely to be kind of seen as indigenous. And in the context of health systems, this means often that they're poorly treated, they're even more marginalized, and they're kind of seen as not really having any understanding of how their bodies work or any kind of knowledge of how to behave, and they need to be taught how to behave properly. And if people are interested in this, we can return to it in the discussion. And in terms of access, it's a very kind of urbanized system. The majority of health clinics and hospitals, as you can see, are in urban centres, whereas only 3% are located in rural areas. So even in kind of everyday life, rural areas are very kind of under-provisioned in terms of what's available. And as well as having kind of poor infrastructure there and poor equipment, they're often understaffed, and it's hard getting human resources across the health sector in Peru anyway, but it's particularly problematic for rural health posts and health centres. They're incredibly understaffed. And even before COVID, there were debates and discussions about the kind of lack of effective regulation and the lack of political will, and that these have been kind of identified by Peruvian researchers as one of the main impediments to improving health systems to meet the SDGs. And as I've kind of hinted already, yes, even sort of prior to COVID, the system was very weak. And in 2018, there'd been a state inquiry into how far the population could access their right to health. And primary care wasn't excluded from the study, but secondary and tertiary care was, so kind of hospitals. And yeah, 251 public health facilities were included in this analysis, and that the research concluded, or actually it was a state investigation, but the study concluded that, yeah, as you can see, 43% of the health facilities did not have sufficient human resources. And one of the issues is that even though large numbers of doctors and nurses are being trained, often they end up in maternal and child health care services because of the kind of emphasis that's been put on this, firstly in the MDGs and then subsequently in the SDGs. So people aren't sort of trained in all aspects of medicine, and or there just aren't kind of posts that are available. So very much kind of concentrated around these sort of narrowly defined services. And also, as you can see here, laboratories, hospital laboratories don't function effectively. So, you know, again, if they can't kind of perform standard procedures in times of non-pandemic, then it raises serious questions about their ability to respond in a pandemic. Also, in terms of the kind of gender perspective, we can see that the Peruvian health sector is highly gendered in terms of the kind of structures, employment structures within the system. The majority of physicians are male, and they are older and more experienced and more likely to be trained in a clinical speciality than female physicians who are younger and less well trained. The majority of nursing staff are female, only a very small percentage are male. And across the health sector, so in nursing and in amongst physicians, there's significant wage gaps. There's been a recent study by the Lancet which provides some data on this, but also female healthcare professionals, and this is kind of across the board, ranging from physicians down to nursing staff, have less access to training and other kinds of benefits. And although there's been a lot of discussion, not just in Peru, but kind of more globally around the professionalization of nursing and how important this is, I mean, one of the big kind of barriers is the gender gaps in education, because professionalization of nursing includes access to higher education and sort of studying nursing at degree level, for example. But if you have gender gaps in education to start with, and fewer women are literate, etc., then you know, it's going to be hard to bridge that gap. And this is also something that's highly class-based and racialized, that, you know, lots of indigenous women and men are very marginalized in the education sector, so the chances of them going to university are pretty minimal. So even though you may get indigenous women working in the health sector, they tend to be very much kind of located at the lower end as nursing auxiliaries or as kind of cleaning staff, etc. And there is this division between the public and the private sector, where in the private sector you tend to get fewer professional kind of well-trained nurses, and they tend to have large numbers of nursing auxiliaries who are less less trained, less educated, but also earn a lot less. So it's much cheaper to run a facility with nursing auxiliaries rather than professional nursing staff. And again, there's a kind of an interesting literature, not specifically on Peru, but that kind of tries to understand the kind of gender dynamics within the health sector. And one of the things that I think is particularly important in the context of COVID is that data, and this data is from Brazil and Mexico, already suggests that female nurses do far more unpaid care work, so kind of work at home in the household, than male nurses, and that they're much more likely to suffer from stress. So again, this kind of raises huge questions about, what does this mean in the context of COVID? And then, sorry, I just have a sip of water. One of the things that my research more generally tries to look at is also to kind of understand the role of households, not just as consumers of healthcare, but also as producers of healthcare, and that this is kind of important to have a broader kind of gendered analysis of how health systems operate. And so again, one of the things that we need to look at is the gender division of labour within households. And we can see from the data here, and this is OECD, from an OECD report, but it's from a time use study that was conducted in Peru about 10 years ago. But I don't think it's that different today, but this is the latest data that's available. But anyway, and we see that, men are far more likely to spend time doing paid work than women, whereas women spend a significant amount more of their days doing unpaid care work, so looking after children, cooking, cleaning, etc. And again, what does this mean in the context of COVID? And I think we've seen in large numbers of countries across the board that women's unpaid care work in particular is rising significantly in the time of COVID. And I think, those of us in the UK have seen ourselves that, queuing to get into the supermarket or to buy a bottle of milk takes a lot more time than it used to. And I think we can all begin to understand these sort of time use differences and how they do impact on our day. And of course, there's variation between income groups, and low-income women, and particularly Indigenous women, do a lot more unpaid care work. And again, two articles that have been in the media this week. I mean, first of all, some of you may have seen in The Guardian yesterday, there was an article about women are kind of bearing the psychological impact of COVID, at least from UK data. And again, there's no reason to suggest that this isn't happening elsewhere. And I think this unpaid care work is quite a sort of significant factor in that. But more specifically in Peru, because of the kind of overloaded capacity of hospitals, they're currently deciding not to accept older patients. They're making decisions about who can and can't be covered. And while of course there's huge ethical issues around that, it also raises questions, about care, and if they're not being admitted into hospital, where do they go and who's going to be responsible for them? And we know from kind of existing patterns that it's much more likely that women in households are taking on responsibility for them. And again, when there's a significant rural and urban divide in terms of social infrastructure and access to clean water, again, what does this mean, in kind of normal times for ability to perform unpaid care work, but particularly, how does this work in the context of COVID if you don't even have access to clean running water in your house? And of course, all of these things impact on households' abilities to kind of maintain health and well-being within the household. But also there are significant gender differences within households and in terms of how households consume healthcare, so how they access the health system, how they buy medication, etc. Peru has a very large percentage of the population in the informal economy, but again, it's much more female intensive than male intensive, or rather women are much more likely to have informal work compared to men. And there's significant gender wage gaps across all of the sectors of the economy. So again, this is important because it determines what kind of access people have to the health system. And if you recall at the beginning, I said, for example, there's the S-Salud, the social insurance system, but very few women have regular salaries where they can contribute and buy that kind of care package. So they are much more likely to be in the public sector. So there's the SIS, where quality of care is very questionable, and access to services is relatively limited. And in the context of COVID, it's the kind of informal activities that where women are most likely to be lag-coated, a bit like the market image in the picture here. And so, you know, women are much more likely to be losing their form of income. And so again, this kind of exacerbates these differences in how people pay for healthcare services and their ability to recover. But one of the most important things, again, particularly in a Latin American context across the region, out-of-pocket expenditure is very high. And we know from research, including from the World Bank, that out-of-pocket expenditure is one of the expenses that's most likely to tip households into kind of downward spirals of poverty. And that they are most out-of-pocket expenditure are most likely to impact on lower income households. And we know already kind of pre-COVID that there are significant gender differences in out-of-pocket expenditure. And here you see data for Peru where for women it's $99 per annum for women, whereas for men it's $75 per annum. And again, I can discuss more why that might be. But again,
one more minute, Jasmine. We're down to 1 minute.
Okay, nearly done. This suggests that the financial burden of COVID in terms of healthcare expenditure is likely to impact more heavily on women. So just to kind of sum up and conclude, we've seen, you know, even pre-COVID, there's been a lack of kind of investment across the public health system. Where there has been investment, it's been in limited areas. But in the context of COVID, this has been more exacerbated. And again, yesterday there was an interesting article in The Guardian where they talked about the kind of problems in the way that Peru did respond quickly in terms of lockdown, but that there has been very little investment in public health care. There's still a significant lack of access to PPE for healthcare workers, and there have been protests in the last couple of weeks by healthcare workers in Peru over this. And we're seeing very clearly that the poorest and the indigenous communities are hardest hit. And it seems very likely that gender and health inequalities are likely to be further exacerbated by COVID, raising very significant questions about the ability to meet these two particular SDGs, but also the SDGs more broadly. And those of you that are interested later, this is a kind of, the video clip on the right is a link to a kind of piece put together by an indigenous community in Iquitos that you may want to look at later. Oh. Okay, thank you.
Oh, thank you very much. Thank you for that, Jasmine. I think moving on, the next speaker is Dr. Khaja Abbas, and he's an assistant professor in disease modeling in the Department of Infectious Disease Epidemiology at the London School. He's also a theme lead with the Center of Mathematical Modeling of Infectious Diseases and a member of the Vaccine Impact Consortium. His research interest is in vaccine impact modeling with a focus on estimating the health and economic impact of vaccination programs. And today, Khaja is going to take us through SDG 3 using an example of one of his studies on the health benefits of routine childhood immunization versus the wider risk of SARS-CoV-2 infections with a focus on Africa. So welcome, Khaja. Thank you very much for joining us. And I think your microphone might be off.
Yeah, can you hear me now?
Yeah, perfect.
Okay, great. And you're able to see the screen as well, isn't it?
Perfect.
Yeah, great. Hello, everyone. It's a pleasure to meet all of you virtually. And during the current ongoing COVID pandemic, not only the health system is stressed in providing the health services for the COVID patients, but the health system is also stressed to provide non-COVID healthcare as well, both essential and non-essential health services. And routine immunization is an essential healthcare service, primarily for children within the age of the first year of life and also in the second year of life. And there is disruption even to the childhood immunization programs in several countries currently. And specifically, here we'll be looking at a benefit risk analysis of continuing the childhood immunization program versus the excess risk of coronavirus infections that can take place at the vaccination facilities and then onward transmission to their households. So this is a study that was conducted with colleagues at the London School, Gavi, and the Gates Foundation. So with respect to the background is that many non-COVID health services are currently disrupted, and that includes the childhood routine immunization programs as well. The challenges being the healthcare personnel are stressed to take care of the COVID patients, as well as the physical distancing measures that are being put in place. It's placing additional stress in providing the regular healthcare as well. And in this context, we are looking at what if routine immunization programs are suspended for 6 months? What would be the impact? And here we are looking at the impact in all the 54 countries of Africa, wherein if we can continue to sustain the routine immunization program versus potential suspension for a period of 6 months. The vaccines that we are considering are primarily diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenza type B, pneumonia, streptococcus pneumonia, which are given at the age of 6, 10, and 14 weeks of age in some countries, and in some countries are given at 2 months, 4 months, and 6 months of age. And the rotavirus vaccine is a 2-dose vaccine, which is normally given at 6 and 10 weeks of age. And also we are looking at the first dose of measles, the rubella vaccine, and yellow fever vaccine, which is given at 9 months of age, and the second dose of measles, which is given at 2nd year of life. The meningitis A vaccine is either given along with the first dose of measles or the second dose of measles, depending upon the country. And we didn't look at the birth dose vaccines, which are basically the BCG vaccine and the hepatitis B vaccine, nor did we look at the polio vaccine as well. So with respect to health benefits, we are looking at the children, among the children that are vaccinated, what is the benefit from the time of vaccination until 5 years of age. But to get this vaccination, when the child and the parent, when they travel to the clinic to get the vaccine, there could be potentially risk of exposure to infection, and thereby, and that particular SARS coronavirus infection that they do acquire either during the travel or at the clinic could also be passed on to their households. Thereby, there's an excess risk potentially of getting coronavirus infections at the clinic as well as during the travel in the community. And we compare it against what if they didn't go to the vaccination clinic, they could have still got the coronavirus infection during the course of the pandemic. So we primarily focus on the excess coronavirus infections that are attributable due to continuation of the vaccination program. And thereby we have the health benefits that we measure by the vaccine preventable deaths that are averted by continuing the childhood immunization program, and we compare against the excess COVID deaths that are attributable to continuing the immunization program. And thereby we compute a benefit risk ratio, and a ratio of larger than 1 indicates in favor of sustaining the routine childhood immunization program. So for all countries in Africa, when you look at it, continuing the vaccines that are given in the first 3 visits, which is primarily diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenza type B, pneumococcal conjugate vaccine, as well as the rotavirus vaccine, what we see, the benefit that's attributable to the household is roughly more than 100 deaths can be averted for every 1 excess death that's attributable to continuing the immunization program. It's roughly in the range of around 37 to 554 deaths can be averted. And when we focus on the impact only with respect to the vaccinated children, like more than 50,000 deaths among vaccinated children can be averted for every 1 excess death that can be caused by the coronavirus infections that are acquired in the vaccination clinics. And when you look at the vaccines that are given in the 4th vaccination, which is primarily at the 9 months of age, which is the first dose of measles, rubella, meningitis A, and yellow fever. Again, when you look at the overall benefit to the household, it's again like 54 to 856 deaths can be averted for each excess coronavirus death that could occur by continuing the vaccination program. And when you look at the impact specifically of the vaccinated children, it's more than 80,000. The reason being why the impact among vaccinated children is much larger is because the children are the primary beneficiaries of the vaccination. Also, they are at the lowest risk for COVID deaths that are occurring in the population. And when you look at the vaccines that are given in the second year of life, the second dose of measles, again, like 2 to 28 deaths in the household can be averted for every one excess coronavirus death attributable to the vaccination program. And when you look at the impact among the vaccination children, it's almost close to 3,000. So when you combine all the vaccines that are basically given in the first year and second year of life, so looking at diphtheria, tetanus, pertussis, hepatitis B, Haemophilus influenza type B, pneumococcal conjugate vaccine, the rotavirus, the 2 doses of measles, rubella vaccine, meningitis C, as well as yellow fever. All these vaccines put together, at the household level, you're looking at more than 140 deaths that can be averted for each one excess COVID-19 death that can be attributed to continuing the vaccination program, and the benefits are much larger when we just focus on the vaccinated children. And then we compare it against a very conservative scenario because of existing herd immunity in the population. When we suspend a vaccination program, it's not that immediately we'll have an infectious disease outbreak of the vaccine preventable disease. Thereby, we presume that almost none infectious disease outbreaks will take place, except potentially for a small chance of measles outbreak, roughly around 1/8 of a chance of a measles outbreak taking place within the next 6 months of period. And even considering under this particular conservative scenario, what we do see is that for almost all countries in Africa, still it's a favorable benefit risk ratio of like around 1 to 21 deaths can be averted for each excess coronavirus attributable death by continuing the vaccination program. And when you look at just the vaccinated children, around the benefit risk ratio is like much larger than 1, like nearly 2,000. That being said, there are other factors that actually influence the strategic decision-making process, because the COVID ongoing pandemic is also creating lots of challenges in the vaccine supply, as well as the current healthcare personnel are also allocated to COVID-19 and other health services. And there are healthcare shortages because of infections among the healthcare staff. And infection risk to healthcare staff who do get infected, there's a potential risk of even onward transmission to their households and in the wider community. And last but not the least, there's a decreased demand for vaccination in many countries. Not only for vaccination, for all essential health services, there's a decreased demand because of the fear among the community to visit the clinics and hospitals for the fear of contracting the coronavirus infections. But that being said, we'll have to counterbalance it with the opportunity risk, similar to the concept of opportunity cost. Like with respect to the healthcare staff, if they were not providing immunization, what other alternative healthcare activities will they be providing? If the risk attributable to the alternative healthcare activities is larger than providing immunization, then it's a much better risk avoidance strategy for them to continue to provide immunization. And also the opportunity risk for the vaccinated children and the parents who go to the clinic. If the alternative activity that they will be involved in has a higher risk of coronavirus infection in comparison to visiting the clinic to get the immunization, then it's definitely beneficial for the children and their parents to go ahead with the immunization visit, even without taking into account the additional health benefits that you get from vaccination. Thereby, the implications for policy and practice, routine child immunization programs should be continued and prioritized for the prevention of vaccine-preventable infectious diseases, because if it is suspended, then what we are risking is, while along with the ongoing COVID pandemic, we are likely to see emergence of new infectious disease outbreaks from the vaccine-preventable infectious diseases. But that being said, the immunization service models will require adaptation. They'll have to involve like infection prevention control measures specific for COVID, even while providing non-COVID healthcare services, and physical distancing measures, personal protective equipment, and good hygiene practices will have to be deployed during the vaccination program. But this will have to be adapted and contextualized to each of the countries and to each of the regions. So in conclusion, routine immunization is essential even during the COVID-19 pandemic. Thanks, everyone.
Thank you.
Thanks, Kaja. That was really interesting. Okay, and now finally, our
Thank you.
last speaker is Dr. Subir Sinha. He's a senior lecturer at the Department of Development Studies at SOAS. His research interest is in Marxist and post-colonial theory, and he explores a wide variety of themes from social movements of the urban and rural poor, contestations over development, civil society, and forms of political solidarity in India, to name a few. And today, Subir is going to take us through these elimination of natural barriers between human settlements and the relative wilderness, and how this both contributes to disease transmission and exacerbates inequalities between and within nations. So welcome, Subir.
Thanks very much, Claire, and thanks to everyone who has logged into the webinar. You know, when we used to have airlines, they used to say, thank you very much for flying with us when you did have a choice of many other airlines to fly on in the good old days. So yes, welcome. I basically want to make 2 or 3 kind of overarching points, and these basically have to do with the politics and sociology of globalization, and also they basically connect with the ways in which particular models of growth both contributed to the origins and the spread of COVID-19 and the virus itself, as well as had a profound impact on how the differentiated experiences of lockdown have been experienced by different social groups, not just in India, but also elsewhere. I mean, one of the things that comes right away to mind is that if you look at the story of the origins and the spread of the coronavirus, that itself is a window on the sad state of affairs as far as the achievement of the SDGs was concerned. So, for example, one question that comes right away to mind is that there's a set of preoccupations with growth. And this growth has basically happened as, within the conditions of increasingly authoritarian populist kind of governments. In some cases, we now, even before COVID, we had seen basically a sharp move from populism to authoritarian populism to forms of political, mobilization and power, which seem to be, almost verging on, to use an old-fashioned word, fascistic. And to me, this has a very strong impact on how COVID was played out in countries like India, but also elsewhere. And also it has some very profound implications on the further pursuit of the goals within the time frame that we have been used to thinking about. Now, take the story of the origins of coronavirus. The more accepted story, though I am aware that this is now disputed by many people across the world, including conspiracy theorists. But the basic idea seems to be that species hopping, pathogens have basically hopped species. And this has happened as a result of, in the original story, so-called wet markets in the city of Wuhan. And if you think about it at a slight level of abstraction, what is basically going on is that there's been a shrinkage of space between high density concentrations of human populations and relative wilderness or forested areas. And we can see that process not just in China, or in fact, not even primarily in China, but we can see that in a variety of different places. We can see, for example, the clearing of land for intensive agriculture in countries in Latin America. We can see the clearing of agricultural, of forested land and the encroachment onto forests for the rearing of livestock or for soybean cultivation. And we have seen, for example, in India and parts of Africa, the large-scale clearing of wilderness areas primarily for the construction of infrastructure or for mining purposes. To go back to a recently famous book by Jason Moore, that basically indicates that the growth model that was being followed by a variety of countries in the recent past depended upon easy access to what he calls cheap land, cheap nature, cheap labor, cheap food, and cheap capital. And the unfolding of the effects of the pandemic, it seems to me, can also be seen through this lens slightly adjusted. So for example, the kinds of growth patterns we have seen where we have the origins of mega cities in some of these cities, for example, that you look at in the map today, which are among the world's 25 largest cities, did not in fact even exist in the period, let us say 30 odd years ago. This would include cities such as the suburb of New Delhi, Gurgaon, Shenzhen. Wuhan itself about 30 odd years ago was a much smaller city. So there's been a kind of a dynamic an exponential expansion in the population of cities 5 to 10 times in the last 30 years. And this population has basically been the expansion in the population can be seen as being accounted primarily by large flows of populations from exactly the kind of areas that I have mentioned to you earlier. In other words, areas that have been cleared for agriculture or have been cleared for infrastructure, have been affected by previous natural disasters. Forms of what in my business they call primitive accumulation, that effectively a squeeze out of human populations into these cities. Now, where do people live in these cities? Now, you can already see that there's been a massive degree of inequality inside urban populations, high concentration of wealth in the hands of very few people. You would see that this is reflected in terms of their ownership of and control over a much larger section of urban space, and therefore a cramming of the urban poor into slums or favelas in many, many large cities of the world. And what this means for us, for our discussion today, is that if you have relatively poor, relatively people without access to healthcare or to nutritious food, large populations in cities, then it also means that cities become the site for great vulnerability to pathogens and a lack of resistance to them, as we can see in city after city. So right now, for example, both Bombay or Mumbai and New Delhi can see high concentrations of COVID-19 positive cases. Now, what happens right after, the sort of perception by leaders that the problem is much bigger than they were thinking, is that there was the announcement of a lockdown. And in the case of South Africa, I'm told that people were given up to 4 days notice. But in the case of India, the notice given was just for 4 hours. So entire economy, or one of the largest economies in the world, in which informal sector labor based in cities, living in highly cramped quarters, already not having access to cash, already not having sustainable access to food or to health, are entirely shut off from any means of making a livelihood. And you see, on television screens across the world or on social media, this endless caravan of migrant workers heading back from the cities into back to their villages. And it's one of the strongest sort of examples anywhere of a reverse migration from urban areas to cities, and in fact also from countries like the Persian Gulf city-states, from which Indian labor has been coming back to India and so on. Of course, being India and with India being in the throes of what I would consider a far right-wing Hindu government, for which the Muslim population has long been a kind of a political problem, you see that the lockdown basically becomes a crackdown on 2 sections of the Indian population. One, it becomes a crackdown on Muslims, and I'll just come to why. And second, it becomes a crackdown on migrant workers. The crackdown on Muslims basically starts off with the identification of a 3-day event held by a small Muslim organization, in which a lot of people later on turned out to be COVID positive, who then also went back to whichever part of India they had come from, and they basically become vectors of the transmission of this particular illness. So you see a complete, in social media and on national television, a complete demonization of not just this particular sect, but because it was a Muslim sect, of Muslims as a whole. And you see also a kind of free hand given to police. Scenes of police brutality against Muslims, are very common to see. And with relation to migrant workers, as they are, basically, if they have no food or cash in the city, and there are figures which show that 90% of them did not receive their wages in March or in April. So they have no cash, no food, no healthcare, and in fact, no means of transportation. They are walking in some cases 1,000 kilometers to get back to their homes. And in the states in which they are passing, we can see that they are being brutalized by the police because they are breaking the lockdown. And of course, they have no other means of getting back to their villages. So in this, one way to think about that is that the coronavirus basically becomes part and parcel of an already ongoing shift to the right within Indian politics and perhaps in politics in other places as well. You basically see the brittleness of the healthcare system. And the main point really about authoritarian populism as it plays out in this particular case is the concern by the ruling party and by government agencies as a whole, particularly the police, but also large sections of the media, that coronavirus should not derail the claim to greatness and therefore to excessive power by leaders, by the strongmen leaders that we have at the moment in many places. What we saw was a near complete centralization of decision making in the Indian case, often overriding scientific advice. So, for example, on many occasions, members of the ruling party, came out on national television and made statements such as that Ayurvedic medicine, and I'm myself a user of Ayurvedic medicine, but that it would actually cure, COVID-19. Or that if you stood out in the sun for 15 minutes, the COVID-19 would be, burnt off. If you chanted religious, songs and shlokas, then again, that would have a negative effect. And I don't want to minimize the impact on social psychology of finding comfort in faith or in religion. But within the Indian case, what basically happened was that this kind of thinking became a substitute for scientific advice. And what we basically begin to see is a widespread circulation of patently unscientific information. Because the recuperation of the image of the great leader becomes more important than solving or addressing the corona pandemic, we also see massive production of false data and hiding of data. So for example, right now, we don't really know exactly how many people are dying in cities like Delhi, but we have estimations from statisticians who are saying that the numbers of people who are being cremated in after dying or are being brought for burial to graveyards seems to be much in excess of what people are reporting as being dead inside hospitals. And in fact, once people die, having shown symptoms, they are no longer tested, and India remains one of the countries with the lowest degrees of testing in the world. So what are ways in which this pandemic might have some impact on the further problems faced by the Sustainable Development Goals in the coming years? And what are some of the ways out that people have suggested? Now, one major suggestion, which comes out of the work of a Greek economist who's based in Barcelona, whose name is Giorgos Kallis, has been that the development model that we have followed across the world for rapid growth, resulting based on cheap labor, based on cheap access to land and nature and so forth, has run its course, and that it, if anything, not only makes the Sustainable Development Goals more difficult to sustain, but in fact, human life itself on the planet more difficult to sustain. And he calls this idea degrowth, that what we need to do is to think of societies that can be organized outside of the preoccupation with growth and with rapid growth than has been the case in the past 100 years, and which has kind of taken on a kind of a turbocharged, if you like, dimension in the last few years. And what is interesting about something that is going on, which could feed into degrowth, is that the workers who have left the cities in India, who have left the large production hubs where they have worked for low wages, in export-oriented industries or in special economic zones have returned to the countryside. They've basically gone back to villages. They say now that they will work in villages. And on the one hand, it has a profound impact on the growth model, but there are certain problems with that, which is that is agriculture, which has long been stagnant in one developing country after another, where food productivity in crop after crop in smallholder settings has been declining. How can agriculture provide both employment to the large numbers of migrant workers who are coming back, as well as produce food for them and for those parts of the population which are not engaged in agriculture? So to me, yes, one condition for degrowth, which is the return of labor from industry to agriculture, has been achieved, but then it does have implications for other elements of the SDGs, primarily with respect to food security. Another dimension with respect to food security is that with the return of migrant workers back to their home villages, there are likely to be massive shortages in labor in agriculture, particularly for harvesting and also for planting of the next crop. There is no political project which is underpinning degrowth. As an idea, it is a very good one. So one thing to look at is how does a political organization emerge from COVID-19, which is going to be, which will take the change in growth models to be the path to take. I'll just end with one sentence, which is that the corona lockdowns across the world have been described as having pressed the pause button on capitalism. And of course, they have stopped the clock in economic and social processes across the world. But it has not hit the stop button on natural processes. In the last 48 hours, what we have seen is a massive cyclone, the largest ever cyclone recorded, has hit parts of Eastern India and Bangladesh. And the devastation it has caused is still too early for us to be able to estimate with any degree of accuracy. So the way in which the corona pandemic now will be dealt in places which have been affected by these kinds of natural calamities is going to, in my mind, unfortunately, further push back the achievement of the Sustainable Development Goals, such as that of social justice, decent work, access to food, and a balance between agriculture and industry. So this is, to my mind, a political challenge, which is not something which is limited to India, but can be seen in different shades in a number of other countries around the world. Thanks very much.
Oh, thank you, Sabir. That was really fascinating. And thanks to my other speakers, Jasmine and Kaja. That was equally, I'm sure everybody would give a silent round of applause for your talks. So I guess we could open it up to the audience. And Goon, you were going to organize some of the questions from the audience around.
Yeah, sure. If you have any questions, just please raise your hand. So we already have one from Prakash Kashwan. Do you want to unmute yourself and just ask your question, please?
Hi, thank you very much. I really enjoyed the presentations, very, very insightful. And I also want to lend my voice to the way Shabir explained the situation in India. Before I come to my question, I just want to make one observation that I really like Khaja's presentation about, how the kind of trade-offs that we will have to start thinking about, at least, from certain perspectives. And it kind of raises the bigger question of the of valuation of human life. And so, what I really learned from your presentation is that we are getting into a phase where human life, or every human life, is no more an absolute, non-compromisable thing. So, if you want to make any comment on that, I'll appreciate that. My question is related to the political project of SDGs. And I wonder if even before the pandemic hit us, did we really have a formidable political project that was able to contest or counter the very deliberate and very open undermining of the SDGs in a number of large countries that have come under right-wing governments that should be talked about. So I think, you know, this idea of political project should not be seen as this kind of problematic, non-technical, non-development kind of issue, because it fundamentally undermines whatever the goals of the SDG community at large may be. And it'd be useful to sort of think about this question, and I would appreciate your thoughts on that. Thank you.
So what speaker would like to speak to that? You crossed both Subir and Kaja's work in particular.
Maybe Kaja, do you want to start off and then I'll pick it up?
Yeah, sure. With respect to the health-related sustainable development goals, actually there has been an improvement in almost all countries. And the primary reason for that has been in the push of the Millennium Development Goals that was set in 2000. And these measures were not only like the goals were set, but they were actually measured. And also a number of global health organizations were basically founded during those times, basically the Global Fund for HIV, TB, Malaria, as well as the Gavi as well. And so some of these organizations, because of the primary focus on these specific diseases, which have some highest disease burdens, like before the last century, the burden have actually reduced, and the interventions, the scale of the interventions actually improved, including in India, wherein the Mission Indradhanush program since 2014 has actually introduced new vaccines as well as scaled up the coverage of lots of vaccines. So with respect to performance indicators, we could say there has been significant improvement, irrespective of the governance and the politics aside. In programs where there's good political will, there has been actually a lot of good progress. Yeah, thank you.
Yeah, I'll just, Prakash, good to see you here. And, a couple of things on that. One is that, I mean, in country after country, you can basically see that there is a kind of tacit separation of some people whose deaths are quote unquote inevitable. And, these are three different sets of populations that seem to me are foregrounded in that. In the Western world, it is primarily the elderly. And you can see that even in the current discussions on the lifting of the lockdown, for example, by the Irish microbiologist Dolores Cahill, who has become a favorite of the lift the lockdown people. She seems to be suggesting that if everyone who was above 70 or 75 and had underlying conditions can be locked off, then it's okay for the rest of the population to enjoy a relatively normal life. And of course, in the so-called herd immunity discussions in the beginning as well, the idea that X thousand of deaths are okay compared to the eventual benefits of everyone achieving immunity without there being a vaccine, also hinted that at high levels of political discourse in advanced countries, advanced liberal countries, there was an acceptance for the death of particularly the elderly. Now, in the case of India, and I suspect in other places as well, there are two populations for whom death is acceptable. And, the philosopher Agamben speaks of these populations as bare life, people whose death does not constitute murder. And you can see the numbers of people who are dying of hunger on the streets of India right now as they are looking to come back to their homes, or who are dying in massive road accidents because they have no proper means of transportation. And of course, in the cases of Muslims within the Indian subcontinent, well, within India particularly, the demonization of that and the demand made by many people on social media that as carriers of the virus, which was an image created by repetition of that particular charge on media and social media, that they somehow should be either locked up or meet violent, consequences from the hands of state agencies or even from private militia. So COVID, it seems to me, has laid bare a kind of an ethical bankruptcy on the part not just of political leaderships, but also of societies as a whole, in which they do see that certain sections of society are less, should not really have a right to life as some other members of society should.
Okay, thank you for that. We have a question from Mark as well.
Thank you, Claire. This is a wonderful, wonderful webinar. The first and last speaker, they made an excellent diagnosis of the problem of marginalization, gender, and poor. In the post-corona era, how do they see a reversal of that trend? Because the picture painted seems to come to me as marginalization is going to be worse, whether it is gender or the poor in the communities, and one might even say poor continents versus rich continents. How do we come out of that dilemma?
Okay.
Respond. Yeah, I think actually following on from Subir's comment, I think that, you know, the COVID has kind of exposed these kind of underlying processes by which, you know, it seems acceptable to marginalize certain communities over others. And while of course there's a lot of kind of global attention on these inequalities at the moment, and you know, a lot of mainstream discussion about gender and the need to address these gender inequalities, I have to say I'm not optimistic that there will be kind of long-term change. And one of the reasons I say that is we look at, you know, all the work that's been done around gender in terms of, say, the SDGs, etc. And yes, we have this SDG about gender equality, but when you look at the way in which gender has become kind of operationalized by the World Bank, by other IFIs, and kind of the you know, kind of donors and those that deliver on development, you see that it's been done in a very sort of piecemeal and instrumental way. So I can see more of that kind of language being incorporated into policy processes across the globe, but whether it's sufficient to bring about kind of meaningful change, which actually requires a redistribution of resources and a redistribution of power, I think that's much less likely to happen. And I can see these kind of issues of, you know, indigenous communities and marginalized women's groups, etc., moving off the agenda within, you know, a few years post-COVID. So I'm not very optimistic, unfortunately.
Well, I just, you know, I mean, if I fully agree with you there, Mark, you know, pre-existing inequalities have been massively exacerbated by COVID-19 and the lockdown. I think we have to see them as you know, as interconnected at one level. Because lockdown itself has such a major impact on shutting down economic processes that employment becomes a very major problem. So if you look at the SDG for decent work or whatever, then, you know, we are looking at a situation where in India, the government itself has come out and said that they would like workers to work for 72 hours per week. You have the Supreme Court of India, which has basically said that in this kind of a situation, employers who have not paid wages for 2 to 3 months should not be punished. There are people who are making demands that labor law should be further diluted, because this would be an opportunity to get firms that are looking to move out of China to set up shop in India. And apart from that, if you just look at it from the lives of individual migrants or groups of migrants, I mean, the tickets on the bus, which, you know, going from southern India, where a lot of migrant workers go to for work, to northern and eastern India, are basically a season's saving for someone. That is entirely wiped out in just going back home. Many people have gone ahead and bought bicycles with whatever money they had so that they can bike 1,000 kilometers to get back home. Now you consider the life of someone who is going back to the family in the area where the cyclone has just hit over the last 48 hours. They've spent all their money to try to get back home, thinking that conditions are going to be better there and that at least they will have access to food. And by the time they get back home, the villages are entirely inundated by the unprecedented cyclone. So, at a time when, government, and I talked about hidden or fake data, Mr. Modi had come out and announced a package with much fanfare. But when you look at the fine, when you look at the fine print, it turns out that he was really talking about schemes primarily that had already been passed prior to the COVID, catastrophe hit. And that is what I mean, that when you have the politics of charismatic, strong leaders around which the entire system revolves, then transparency for data, in our case, also massive suppression of civil society organizations, all of these have been ongoing. And the centralization of power in the hands of very few people, which I think goes back to Jasmine's point as well, we need a redistribution really of not just resources, but of political power as well, which there was a period until maybe 2003 or 4 when that was going on in many countries. But since then, the direction has been in the reverse, where power is getting concentrated more and more in the hands of fewer and fewer people.
Okay, thank you. We have another question, and this time it's from Amina. Amina, could you unmute yourself?
Yes, hi. So I'm Amina, and I'm from Tanzania, and coming from the NGO space, right now we're currently seeing a lot of changes and a lot of innovation happening in all other sectors. Subir talked about authoritarian governments and everything that is, all the changes that are happening. And I was just really curious to hear from the speakers today, and maybe from anyone who's listening, that, we as NGOs, what kind of innovation do we need to think about with the current changing space that we can actually bring in? Because as far as we know, in the global south, NGOs have been at the forefront of the SDGs and trying to make sure that we reach the target. So what kind of innovative measures do you think, as the NGO sector, we also need to adapt as fast as every other sector is adapting to these current changing times?
Who wants to answer that question?
I don't really have a clear answer, but I think, maybe one thing to flag up is that obviously one big concern that's emerging is the financial challenge that many NGOs are now facing. And I think what will be interesting to see is what NGOs, or which NGOs, are able to survive this. And again, yesterday, I think we heard in the media here about, extensive job losses in Oxfam, etc. And I think one thing that concerns me is that the kind of NGOs that will be able to survive are those that have close links with international financial institutions and receive funding in particular ways, like maybe through the Gates Foundation or the World Bank, not directly, but kind of in projects linked to that, and that may kind of limit the kind of innovative work that they're able to do, and that NGOs that are perhaps more independent and have alternative sources of income, so have that freedom, perhaps those that are less likely to survive this. So I think there are serious questions about, what kinds of NGOs will emerge out of this, and what space they have for doing kind of critical work that really sort of engages with the kind of populist regimes, etc., in ways that could be transformative.
Can I just say that, in my view, and there's been a considerable literature on this as well, NGOs around the world since about 2010 onwards, India, Uganda, other places as well, Ethiopia, there has been an assault on the NGO sector going on for a while. And, you have countries that basically say, who are you to interfere in what we do to our nature or to our population? This is our national sovereignty. So states have basically tried to reassert their sovereign power over their population and their territory, and have banned or otherwise seriously curtailed, NGO activities, particularly those which are funded internationally. Words such as "you are an agent of the West," etc. These are also not uncommon when certain NGOs take up positions against the government. In the case of India, tens of thousands of NGOs were basically deactivated by the Modi government since 2014. So one very interesting thing that has happened and this is probably just tangential really to your question there, is what one of our sort of Indian sociologists calls the rebirth of the social. And what he's really talking about is that, at two levels, having attacked the NGO sector massively, the Modi government realizes that in order to do relief work in the immediate aftermath of the arrival of COVID-19 and the lockdown, there isn't enough state capacity. So they go back to NGOs and they take help from NGOs in the provision of relief measures. The second is the emergence of new kinds of networks of solidarity, particularly with those people who are victims of the lockdown or of state violence that followed after the arrival of COVID-19. So, I mean, there is a network that you can find on social media, which is called Stranded Workers Action Network, or SWAN, okay? And what you will find in that is that they're basically people saying, hello, I'm in X city, and there are 150 workers, and they're looking to get back home, which is 700 kilometers away, and they have no food. Can someone please provide for them? And then you will have people, likewise on social media, you have groups like the migration groups and things like that, which are fairly organic. Some of the members there obviously are coming from already existing NGOs or from other civic associations, but the networks themselves are relatively new, which is that they have emerged to provide absolutely immediately required sustenance and welfare provisions to those people who are the victims of both the disease and of the state incompetence in dealing with that kind of pandemic and the lockdown. So to me, this is an opportunity to think about the NGO space in a slightly different way. In the sense that we have had established NGOs, many of them are, as you know, internationally networked and funded. We are looking at a time in which globalization as we knew it is in some retreat. And to that extent, the idea that you do have the emergence of local networks and local organizations which are close to the ground and are able to respond quickly to issues which are of a life and death matter, it seems to me shows a certain degree of resilience within societies, which had been switched off, I would say, in the last 4 to 5 years. And for us going forward, it would be very important to try and build up a new kind of associational space with these, if you want to call them green shoots.
Okay, thank you. I think we're running out of time. Claire?
Yeah, is there one more hand? There's one more hand raised.
Yeah, we have a question from Shireen. Shireen, do you want to ask your question?
Okay. Hi, I'm not sure if I'm unmuted.
No, we can hear you.
Oh yeah, great. Okay, thanks. Actually, it wasn't. I did start off wanting to ask a question about religion and its impact on healthcare messaging. But we do have a seminar on that on the 4th of June, so maybe I'll leave that till then. I think now I've changed my mind, and I just kind of not confident enough to issue a call to arms, but I think it's very easy when you look at the world and you listen to Jair Bolsonaro and the president of the US telling people to inject light and bleach, and you see what's happening in India. It is hard to not feel a little bit sad, depressed, demoralized. But I remember in the 80s standing outside South Africa House when people were telling us that Nelson Mandela was a terrorist and should be hanged. And you have to just keep on. If you look at what's been happening just before COVID-19, we had so many young people globally marching and campaigning and just about to affect real change on the climate. These things can happen. We do have, social media. We do have people who are pushing for kindness and compassion. We do have expert academics like you that bring us information about what's happening in Peru, what's happening in India, why we need to vaccinate. And we just need to redouble our efforts to get these messages out there to counteract all the crazy and the populism. So I think I just want to kind of urge people to keep their peckers up and not lose hope. it is possible to keep, to meet the SDGs and to carry on working for that. And it is possible to push back against global inequalities. So I think I just didn't want my own spirits to sink after hearing all this information, because we do know that change is possible, but we have to work for it. So that's me. Thank you.
Thanks, Shireen. I think that's an absolutely brilliant thing to end on. And I just want to thank our speakers. Jasmine, you took us through this cascade of vulnerability, landing on the most vulnerable of Indigenous women. Kaja gave us hope that SDG 3, that there was progress. And I think, Subir, I think everybody can recognize your depiction of these recuperation of the great leader. I mean, that is just so spot on. But I think, I agree with Shireen. I very much agree that, the nation state is not going to be up to the SDG. And this is going to have to be grassroots and talking about these green shoots of new ways to organize ourselves to do it ourselves. So yeah, thank you so much for this seminar. I thought it was really, really wonderful. Thanks to our speakers and our audience. And onward to the next one, as Shireen mentioned, on June 4th. So
Thanks very much.
Bye-bye.
Thank you. Bye.
Sounds good. Thanks, everyone. Bye.
Thank you. Bye, Kaja.
Yeah.